Um, so this is a really interesting topic. I'll just introduce myself first. I'm Trivedi. I'm a radiologist at Emory. I work in the emergency department, or the emergency division of radiology. And I spend about 50% of my time doing clinical work, and then the other 50% um, uh, co-directing a research lab here that focuses in artificial intelligence. But I spent a lot of time over the past few years uh, involved with industry and trying to get a handle on what the path forward is for deployment of AI solutions. So I kind of have this special interest in business applications to radiology AI. And then I also just want to preface this talk with, the fact that some of the things in this presentation may be a little bit cynical in the sense of, it's not an ideal system in which these tools are deployed, and the incentives and value propositions are sometimes not aligned with the patient's best interest. And so I just want to throw a caveat in there that I don't really advocate that this is the way that things should be in the business of radiology AI, but by and large, from a lot of conversations I've had in dealing with companies, that this is the way they are right now, which is a result of our healthcare system reimbursement structures and things like that. So I just want to kind of say that these are not my personal opinions of the way things would be in an ideal situation. Here are my disclosures. I won't be discussing any of these companies directly in today's talk. So the objectives today are twofold. First, we'll talk about the business of radiology AI, and I caught the tail end of Jordan's presentation, and so we'll talk a little bit about touch points in radiology AI workflow, everything that happens before and after an image is generated and interpreted, available types of models by modality, by body region, and also by point in the value chain. And then I think most interestingly are the economic considerations. And then I also want to talk a little bit about the ethical considerations of radiology AI models, and talk about bias and understand a little bit about why AI models become biased, examples of model bias, identifying some sources, and ways to potentially mitigate this bias. So if we look at radiology workflow, and this may have been covered before, there's many steps before we get to the central part where we as radiologists are involved, right? So we start all the way from acquisition and image pre-processing. We have image generation, and then image-based tasks is where we do our job as radiologists and generate reports. And then we ship it off into the ether with the hopes that whatever we recommend gets read by the appropriate clinician and acted upon or followed up, right? And the interesting thing is, what the things outlined in red here are the areas that we as radiologists focus on the most, is image and image interpretation. But in fact, the majority of AI models that are clinically deployed right now and FDA cleared actually focus on everything before and after, which is the areas highlighted in green. And the ACR maintains a really nice website where they track FDA cleared AI models. And this was as of May or June, so this is a few months old, but as of June, as of a few months ago this year, there were 193 FDA cleared models. 54 alone were cleared in 2021, and 28 were cleared as of June or July of 2022. And so we're on pace to clear as many, if not more, this year than last year. And if we look at the breakdown by body region, you see concentrations for neuro and chest, and we'll talk a little bit about why that is, with a tie for third for breast and cardiac. And if we look at modality, you see about half in CT, about a quarter in MR, and then the remaining quarter made up by the rest of the modalities. And when you look at the intersection of these two, you'll notice that there's 5 major areas where we see AI models deployed, right? And those are the ones highlighted here. So chest CT, chest radiograph, brain CT, brain MR, and mammography. And if you think about why this may be, it's a combination, in most cases, at least for chest CT, chest X-ray, and mammography, they're amongst the highest volume studies, right? So small movements or small impacts in performance have large downstream consequences because the sheer number. So if you say 5% of time on a mammogram and your institution reads 40,000 mammograms a year, that adds up to a lot, versus if you save 5% of your time on a breast MR and you only read 1,000 a year or fewer. And neuro CT and neuro are not as high volume, but they're very high acuity, right? So think about stroke and hemorrhage. So we see concentrations of models in areas where there's potential to be high impact. And so I get this question a lot of, well, why don't we, why isn't anybody developing models for peds, or why isn't anybody developing models for pet? And every model developed still takes an extraordinary amount of time, effort, and money. I mean, the time and effort to develop an FDA cleared model beginning to end is somewhere in the 1 to 2 year range if everything goes perfectly, and usually around $250,000 to $1 million minimum. That's before marketing, that's before sales, that's before deployment, right? So as ideal as it would be to create models for less common studies, for example, pediatric brain tumors, from a financial perspective, that's not really viable right now because of the time and effort involved in doing that. And then if we look at types of clearance, this is something I learned about when I was first making this talk, is that we talk about CAD, and most people, when they hear CAD, they think about computer-aided diagnosis and mammography. But CAD, computer-aided detection and diagnosis, is split up into 5 categories. So you have CAD-E, which is basically cleared for detection of abnormalities, but not for characterizing those abnormalities. So just localize that this is an abnormal area. And inversely, CAD-X is for characterizing the lesion, but not localizing it. So for a CAD-X model, the radiologist would have to localize the lesion, and then the CAD-X model would characterize it. And then you have the intersection of those two, which are both detection and diagnosis, or detection and characterization, which are harder for clearance, more expensive to get cleared, more evidence required, and so those are less common. Then we have triaging, which doesn't really focus on detecting or characterizing abnormalities, but simply alerting the user to the presence of a potential abnormality and triaging that to the top of a work list. And that's fairly common. And then you have the last category, CAD-A and CAD-O, which is acquisition and optimization. And I caught, the tail end of Jordan's talk, where, this is a big area that's ripe for improvement because it's behind the curtains. But again, if you generate a model that decreases noise or improves, scan times, cuts MRI scan times in half while maintaining image quality, that has enormous downstream consequences. And you don't have to worry about the model actually diagnosing anything and proving that it can. You just have to prove that it maintains comparable image quality, for whatever parameters you've set. And so if we look at this, down in the bottom right corner is less than 1/10 of all models, CAD-E, CAD-X, and CAD-E and X combined, right? And then you have maybe 1/4 of models that are CAD triage, and then you have 2/3 of models that are for acquisition and optimization. And so if we think about why this is, we have to think about, what are the business considerations of radiology AI? So I'd like to think of this in 5 major bins. So we talk about improvements in efficiency, catching of incidental follow-ups, beneficiaries that are not radiologists or not the radiology department directly, reimbursement structures, and then impacts to quality and safety. And so if we talk about acquisition efficiency, this is something I touched on earlier. So if you can improve acquisition time, and you can take, a spine MR down for a SAGE-T2 from 2 minutes down to 1 minute, and you apply that over a dozen studies a day, cut that time in half, you might be able to squeeze an extra 2 or 3 patients on the scanner. And, this is something that most people don't, maybe a lot of, especially residents, don't know about, but professional fees and technical fees are very, very different. So we may get paid something like, $50 to $100 for interpretation of an MR. The technical fee for that the hospital collects, or the imaging site collects, is $2,000 to $3,000, sometimes more, right? So you talk about squeezing in an extra 3 MRs per day, and you're generating revenue in the tens of thousands, extra $10,000 a day easily, right? Same thing, here's an example. This is a research model that reduces noise, and you have a sequence on the left that was acquired in half the scan time, reconstructed using a generative adversarial network to decrease the noise on the image, and you get equivalent image quality. This is this company called Subtle Pet. I think Jordan talked about this topic probably, so I'll skip over it. But basically, in a 1 minute acquisition scan time, you have similar image quality to a full 4-minute acquisition after the image is reconstructed using deep learning. Post-processing, this one's kind of interesting, right? So I read a lot of, I trained in MSK, but I work in the emergency division. We still read a ton of x-rays. I probably read 100 x-rays per shift. And the entire time my finger was on left click, dragging around window leveling to look at soft tissues, look at, bones, look for gas. Even looking at the bones, if you guys ever think about reading a foot radiograph, the toes are usually not exposed the same as the forefoot or the hind foot or the midfoot. And so if the toes are blown out, if the hind foot is in appropriate window level, the toes are blown out, right? And so having to do this constant adjustment, there's a company that developed this post-processing technique that will generate these post-process images that will allow you to see everything at once and perhaps cut down on the time you have to spend window leveling, right? This is a really simple one. So we have this issue a lot. We have 2 sites where our technologists reconstruct our images for us and straighten them out. And then we have 2 sites where they don't. And studies have shown that reading a crooked image decreases radiologist sensitivity and slows us down. So something as simple as straightening a head CT or a spine CT can make improvements in efficiency. And then we have, this is obviously Dr. Smith's software AI metrics, right? So this is anything to improve efficiency with interpretation. So automatic measurement of lesions, automatic comparison with priors, and applied at scale, something like this could have a lot of time savings, 20-30% maybe or more time savings if you're in the body division reading 20-30 oncology cases a day, right? So that really adds. Same thing, lung rats, lung cancer screening, right? So automatic detection and characterization of lung rats nodules, which we know, is not technically complex. It's a low value, low skill task. You could probably train, a college student or a undergraduate or a high school student to do this task. I don't think even a radiology resident is required to do this. So taking some of these low skill, kind of high tedious tasks and automating them could improve efficiency as well. Similar concept for MS lesion quantification. I don't know if we have any seniors here, but if you've done neuro-MR and you're fortunate to come up with a come across an MS case, and you have to measure and compare and contrast 10 different lesions when the planes are slightly different and the imaging technique is slightly different. This case could easily take half an hour, right? And so automating something like that down into 5 minutes is a huge time savings. Another category is capturing incidental follow-ups. And from a patient perspective, it's a no-brainer, right? You caught something that needs follow-up because there's a risk to the patient. You want that patient to get followed up, no question there. From a financial perspective, there are some advantages here. So capturing that follow-up study has a bunch of downstream financial benefits. It's the immediate revenue from that downstream scan, right? That comes in. Right now, we're still fee for service in the United States, so you get paid for that. The department gets paid, the hospital gets paid. And then, more interestingly, you also have what's called patient capture. So if you recommend a follow-up for an adrenal nodule, they get their triple phase and, ends up being something that needs to be operated on. You've captured that patient in the health system and potentially generated tens of thousands of dollars in revenue. So closing the loop on follow-up is one of these nice win-wins where it's good for the patient, but in cases, even if it happens a few times a year and you capture those few extra patients, which otherwise would have been lost to follow-up, you can generate a lot of revenue for your imaging department or the hospital system. And then there's this theoretical benefit of decreasing medical legal liability, right? So decreasing lawsuits related to lack of follow-up. And, my opinion is this is not proven out in the wild. And when I look at pitches or when I'm, receiving a pitch from companies looking to sell their models, they actually don't focus a lot on reducing medical legal liability because it's hard to quantify and it's a little bit hard to prove of how many actual fewer cases you would miss and how much those lawsuits might potentially cost. So again, I don't advocate that this is the right way to look at things, but this is a little bit of the reality of the way things are looked at when it comes time to open the pocketbooks and sell models. This one is actually one of my favorites because the way I came across this is last year at the RSNA, I was part of a session discussing the business of radiology AI. And so as a part of that, I interviewed around 25 different individuals from, C-level executives at startups, big companies, informaticists, department chairs and vice chairs, private practice rads, academic rads, and began to really understand that the role of the actual radiologist in liking or not liking a piece of software and its eventual likelihood of uptake, uh, that relationship is pretty thin, right? Because there's a lot of other ways to provide a financial benefit to a hospital system besides just efficiency improvements. And so if we think about this example of models that have been recently published for automatic detection of coronary artery calcification on non-gated chest CTs, if we deploy a model like that in our department, that's potentially something fantastic for from a technical standpoint. That's really cool, right? Opportunistic screening for coronary artery calcification, get that information into the radiology report, and hopefully it lands in the lap of somebody that can do something about it, right? If a 50-year-old or a 40-year-old has high CAC burden, that's unexpected. But the truth is, as a radiologist, I don't benefit from that per se, right? So if you go to a radiologist department and say, hey, well, this piece of software is $50,000 and we're automatically going to detect CAC in your non-gated chest CTs and put it into your report, you say, well, that's great, but that costs me money and doesn't necessarily generate any additional revenue from the department. So that's it's a nice to have, but it's not a need to have. And hospitals are always cash strapped, right? So that type of model to improve quality falls kind of lower on the priority list. But instead, if you go take that same model of cardiology and say, hey, look, I can run these on every non-gated chest CT and flag patients that are at high risk unexpectedly and generate referrals to you in cardiology. And hey, maybe a few of these patients every year will receive an intervention, a cath, a stent, a hospitalization, a cabbage. Now, you've moved from saving a few bucks or few minutes on interpretation to, again, generating admissions, DRGs worth tens of thousands of dollars, right? So it turns out, and the same thing in the ED, if we read, if UAB is a big academic center, right? So your guys' ED turnaround times are probably just as fast as ours. I read a head CT, nothing stays on the list for more than 5 or 10 minutes. So if I shave 2 minutes off my head CT time, it doesn't do anything for me as a department. But the ED might care about that, right? The ED might care about patient turnaround times and getting patient throughput through the ED faster, getting those results faster, even if they're prelim. So these models often get pitched to the emergency department for those reasons, decreasing wait time, things that are tied to their metrics as a means to pitch. And then the ED comes to us and says, hey, we'll pay for this model. Are you okay if we deploy it? Because it's really going to help our bottom line a lot more. Right. And then another really interesting thing is identifying patients that are eligible for drug trials. So there's a company that created a model to detect nodules on chest x-ray and ran it retrospectively on 100,000 patients at an academic institution. And the reason was because a pharma company had developed a new drug that was really beneficial for early stage cancer. But the problem was they weren't catching enough patients, not enough patients were being diagnosed with early stage cancer in order to be enrolled in the trial for this drug or in order to be potential purchasers for this drug. So they partnered with this AI company to run this retroactively on 100,000 patients, found, a few dozen high risk nodules on retrospective chest x-rays done in the last 6 months that weren't detected by radiologists, biopsied them and actually found 10 or 12 early stage cancers, which now are enrolled in this trial or maybe on this drug that's worth $50,000 to $100,000 per patient, right? So you've generated $1 million in revenue from capturing 10 to 20 extra patients, right? Touching briefly on reimbursement. So a few years ago, Viz AI was one of the first companies to get reimbursement for large vessel occlusion detection. That has been adopted pretty extensely now across the country. And last year, 2 CPT codes for vertebral compression, fracture, and bone density were also approved. So we have 200 models. We have reimbursement for 3 of them. But eventually, I think adoption will be driven by the ability to get paid for use of these models. And it remains to be seen what happened with CAD in breast imaging, if I'm not mistaken, is initially it was kind of an additional payment on top of reading the image without CAD. And eventually it just all got lumped together, where essentially if you didn't use CAD, you were losing money. And we may get to the point where the reimbursement structure is, these types of scans are being expected to be read with AI, and you'll get reimbursed extra for that in the beginning, but eventually it'll just be lumped into your payment. And then the last thing is billing and coding, right? So billing and coding is done manually. If there's any faculty on the call, I get emails once a month saying, oh, you forgot to mention this thing in your report, or you didn't mention the laterality, we can't bill for it, please fix it, right? So automation of that process and automation of extraction of diagnoses or billing codes from reports would save a ton of manual labor, right? And probably allow us to maximize the amount that we bill and code for every exam. And then we talk about quality and safety, right? So this is where I kind of think that, the incentives are not well aligned, right? So we have things that improve interpretation quality. So what that means is just catching things that we miss or characterizing them better, whether it's fractures or tumors, or, improving recall rates on mammography, or improving the inter-reader agreement of BI-RADS scores on ultrasound breast masses, right? The issue is, these are great, but any of these models that I just described don't affect the payment structure, right? So you could argue that, okay, characterizing this breast mass better will avoid biopsies. But if you take that to a radiology group and say, hey, we're going to reduce your number of unnecessary biopsies by 20%, you've in effect told them that you're going to reduce their biopsy revenue by 20%, right? And in an academic center that has a broader mission may be okay with that, but if you take that to a private practice, they say, well, we love doing procedures, we get paid for those, right? And so same thing with dose reduction. I don't know that, to be very honest, I don't know what the payment structure is for gadolinium contrast or tracers. So I'm not sure if money gets saved if you use 10% fewer, or if you only use 10% of the total dose of gadolinium. I don't know if you save money. I certainly know that you probably bill the same, whether you use 10% of the dose or the full dose, right? So, a model that reduces the necessary dose may be good for patients, but I'm not sure that it affects the bottom line. Same thing in PET. And so the truth is, right now in our fee-for-service system, quality improvement has a difficult path to profitability. So in summary, I think we have to think about the large economic value chain of radiology AI and think about models that extend beyond just what we do in interpretation, and think about, if we really want to create a business around radiology AI, what are the other touch points in the workflow that we can affect? I've only got about 3 minutes left. I'm going to run through this really, really quickly. I wish I had more time for this, but just on AI ethics, because I do want to leave a couple of minutes for questions. So why are models biased? Well, as you may have gathered from from the previous presentations in this series, they're very, very good pattern recognizers, and they'll discover patterns in data, whether they are real or confounded or artifactual, right? And so models that are trained on general populations overfit to those populations, and when you deploy them on external populations, they tend to fall apart, right? There's plenty of examples of these, right, in dermatology and ophthalmology, in predicting which patients need higher levels of care. And if we look at the sources of this bias, it's because the intrinsic data that goes into the models may be biased not intentionally, but often unintentionally, right? And so, a good example of this is if we look at, the rate, this chart is showing the rate of pregnancy complications, or I think postpartum complications, by race and income. And the rate of complications is higher for Black patients with a college education than it is for white patients with a high school education, right? And so if you train models on these types of data, no matter how well intentioned you are, you still may end up with a biased model, right? And one of the interesting things we found and published on earlier this year is that there is intrinsic information in the images themselves. So we took our group, namely Judy Kachoya, who's my partner here at the lab, took half a dozen or more different data sets: chest X-ray, chest CT, mammography, spine X-ray, body CT, body MR, and trained a model to perform a simple task: predict the race of the patient based on a single image, whether it's a single X-ray, a single head CT slice, a single body MR slice. And found here, in most cases, that the AUC for predicting the race of the patient based on one image was anywhere from 85 to 99%, right? And you ask a radiologist to perform the same task and their AUC is something like 55%. So it's essentially random chance. And what that means is that there's intrinsic information coded in the image about the race of the patient that we don't know about and we don't know where it comes from. And we spent a lot of time over the past year trying to decipher this. So ways to mitigate bias is, this might sound like a throwaway answer, but diversify your team. And the reason for that is issues that are specific to patient populations sometimes are only discoverable or only known to patients known to people in that group of patients, right? So if there is something that's, culturally or culturally or socioeconomically related to one group of people, having a researcher that's part of that group of people increases your chances of discovering that subpopulation or that potential bias. There's a lot of techniques to improve dataset diversity, which I won't get into, but we can generate synthetic images that represent patients from different subgroups. And then there's various debiasing techniques like adversarial debiasing, in which you penalize a model for learning a protected attribute while still learning the information desired. So you penalize it for learning race while still rewarding it for detecting cancer. And so what should I do for mitigating bias? First of all, be aware that this is an issue. Collect attributes for these patients. So collect race, collect ethnicity when you're creating your data set, socioeconomic status, zip code. Perform subgroup analysis of your model performance. So actually investigate not just this model performs with an AUC of 90%, but how does it perform in old people, young people, Black people, white people? Attempt to balance your data set and augment your data set to improve any issues in imbalance. And then finally, if all of those things fail, try some of these advanced debiasing techniques. So that'll end. Still got 2 minutes to spare. So I'm happy to answer any questions. Thank you.
That is really fantastic. Thank you so much, Dr. Trivedi. Yeah, I'm really glad that we were able to discuss the economics and ethics. It's two topics that I think go together so well, and you've addressed them excellent, really, really well in the very short time that we've been able to give you. So thank you so much for giving us this time. I do have, so I have one question in the chat that I was hoping to send your way. So it is, what AI solutions are the best to buy from an economic perspective in a radiology department?
Yeah, so the easy answer to that question is it depends, right? It depends on a lot. It depends a lot on what you do. Are you an outpatient imaging center that reads a bunch of outpatient CTs and exams that are a day or two old? You may want a triaging solution, right? If you're reading a lot of oncology cases, you may want something for automatic characterization. And oncology solution doesn't do anything for me in the emergency division because we don't read a lot of those cases. But I think a broader answer is I still really believe that the part of the value chain that's most financially valuable right now is this area here where we talk about, CAD-O and CAD-A, this optimization and triaging, not triaging, excuse me, optimization, acquisition, and pre-processing. Because, a lot of manufacturers are building these into their scanners now and using them as a means to sell new scanners, right? A new CT scanner with an inbuilt noise reduction model or in a faster acquisition time that's focused on deep learning. And I think that from strictly an economic standpoint, I mean, if you can do, 2 or 3 more MRs per day, and you have 20 MRs in your enterprise or 25 scanners, that adds up to potentially in the millions of dollars of additional revenue per year. So I think that's probably in the short term where we go. And then I think Dr. Smith typed another question. Do you think there'll be more reimbursement for AI and radiology in the future? Will body composition metrics that predict cardiovascular disease be reimbursed? I sure hope so. I think anything that benefits, I mean, if I was a payer, I would say that we should pay for that, right? Because population level health control is a big issue, right? And so if we have models that can improve population health by detecting risk or detecting risk factors what we like to call opportunistic screening. So as byproducts of the body CT done for another reason, or as a byproduct of a chest CT done for another reason, and those models are paid for, eventually that could be used to improve population health. And, getting a stent, before an MI, I would imagine costs 5 times less than doing an emergent hospitalization in a cabbage, if not more, right? So if I was a payer, I would say, yeah, we should begin paying for these things, because in the long run, it's better for patients, but it'll also save the payer money. But time will tell. There's a lot of external factors that go into this, and a lot of politics. I talked to Rich Duzak, who's heavily involved with the RUC, and he mentioned that we don't have time to go into it, but there's a lot more that goes into weighting what gets paid for each exam, because it's a zero-sum game, right? So if something goes up, if we get a reimbursement for an AI, a CPT code for an AI solution, something else has to go down, right? And I think that's a challenge.
Absolutely. Well, we do have one more question here, and I'll this was one for my session earlier, and I'll pose it to you as well. From the nuclear medicine side, what type of AI algorithm do you most want to see? And it might just be a lack of imagination, but I think 2 of the areas that are already being researched that would complement each other well and could work in tandem would be some of these solutions like deep learning reconstruction that can increase the patient throughput by decreasing exam time, and then also partner that with some of these tools that might be able to automate some segmentation and quantification and make the radiologist interpretation faster. Because I don't know about your department, Dr. Trivedi, but there aren't many departments that I know of that would say, oh yeah, I can handle double the amount of cases today.
Right.
So, yeah, we are approaching that asymptote of radiologist performance, and to have some of these tools that increase the amount of scans. What value is that really doing if we don't have the time to read them?
Yeah, I think I agree with both of those answers. I mean, I think increasing throughput is great. And there's this issue. I mean, I always think about this too. I know that cardiology at Emory is booked out for 3 months. So what do I care if my coronary artery calcification model generates an additional referral to cardiology? They're not wanting for additional work, right? They're booked out. So I asked about this, and the answer is actually that hiring and expansion in healthcare always lags behind demand. You never expand before the demand is there. That's why our radiology department and healthcare in general is always in a perpetual state of being at the very edge of what we can do, right? So I think that what would happen is if you did have a model that could double the throughput, eventually you would see that and you'd be generating the revenue to then double the amount of nuclear medicine physicians, right? Or double the size of the department. But that in between time would be a pain period. And obviously there's this question of shortage, like do enough nuke med radiologists exist to fill that gap? But my understanding is that essentially, if there is a demand, then eventually the supply or the hospital staffing or the department staffing will catch up. It just unfortunately does not often happen proactively. It always happens as a reaction, and that's because you don't want to end up overstaffed with not enough work to do. Right? So, but that's a very good point.
All right. Well, thank you so much for your time today, Dr. Trivedi, and thank you all for joining us. We will be reconvening tomorrow for the course review very briefly, and then we'll be getting straight into the hands-on session. The registration link is in the chat and it's still open. And for anyone that wants to continue this informatics AI education in the future, feel free to, or I'd recommend you follow us on Twitter. We'll hopefully be having this course again next year. And for those of you that are first year, second year, third years, and want to pursue this in your fellowship, we have an informatics fellowship here at UAB, which I'm currently a part of, and it's been a really great opportunity to further my own education. Dr. Trivedi, it sounds like you guys have a great infrastructure at Emory, and we have spoken with Dr. Yee and Dr. Parekh in Maryland. Certainly, we have a lot of experience here with clinical AI implementation. So if you're interested in that, please feel free to email me. And otherwise, I will see you all tomorrow.
Thanks very much. Bye.